Hello everyone and welcome to our module on Cppd. Cppd is calcium pyrophosphate deposition disease, and in this disorder, calcium pyrophosphate deposits in joints and connective tissue. The reasons this happens are not well understood. If you look at the bottom right side of the screen, this is the structure of pyrophosphate. It's two phosphate groups linked by an oxygen atom. And if pyrophosphate binds to calcium, that is calcium pyrophosphate, and that's what deposits in joints and connective tissue in Cppd. And as we'll see, this disorder shares some similarities with gout. In gout, uric acid deposits in joints. In Cppd, it's calcium pyrophosphate. The main difference between gout and Cppd, especially in terms of step 1, is that there's a lot of biochemistry around what produces more uric acid and leads to gout. There's not so much biochemistry around Cppd. This is a disorder of older patients. The average age of onset is 72 years old. It occurs in men and women with equal frequency. And there are basically three clinical patterns of Cppd. Many patients are asymptomatic, and the disorder is discovered on routine imaging. There is a variant of Cppd where patients develop an acute arthritis. This is similar to gout. And then finally, many patients with Cppd develop chronic joint disease similar to osteoarthritis. And osteoarthritis and Cppd are both disorders of older patients, and there's a lot of overlap in terms of the symptoms. So let's talk about that first clinical presentation of Cppd, which is asymptomatic disease. So if you study patients and image their joints, you will find lots of joints that have evidence of Cppd but have no symptoms. The only way you can identify the presence of the disease is by seeing the crystal deposits discovered on imaging. So the hallmark of Cppd is something called chondrocalcinosis. This is calcification of the hyaline cartilage from deposition of calcium pyrophosphate. This is an example shown on the screen here. You can see this white stuff here in the joint space. That is chondrocalcinosis. So this is often discovered on imaging when it's done on patients for routine reasons, and it may be discovered in a joint that has no symptoms. That's a very common presentation of Cppd. The second way that Cppd can present is as pseudogout. Pseudogout is an acute attack of arthritis that resembles an attack of gout. That's why it's called pseudogout. And the classic joint to be involved in an attack of pseudogout is the knee. The knee is involved in 50% of cases. Patients present with pain, redness, warmth, and swelling, just as is shown in this picture on the screen here. And gout can also involve the knee, so the only way you can differentiate the two is by aspirating the fluid and sending it for tests, which we'll talk about in a minute. And always keep in mind that if you see a board question describing an acute onset of arthritis of the knee, the three things you should think of are gout, pseudogout, and septic arthritis, and they can all be differentiated by analysis of the synovial fluid. In the video on gout, I talk about a number of classic triggers for an attack of gouty arthritis, and all of those triggers lead to high levels of serum uric acid. There are also some triggers that have been established for pseudogout, although the mechanisms of these triggers are less well understood. So the first thing you should know is that pseudogout often happens to patients who are sick. So if they've had trauma, or they just had surgery, or they have a serious medical illness, these things are all associated with a higher likelihood of developing an attack of pseudogout, and therefore you often see attacks of pseudogout in hospitalized patients. In addition, many flares of pseudogout have been reported after parathyroidectomy for hyperparathyroidism. So when you remove the parathyroid gland, the calcium levels will fluctuate, and so it should be easy to understand that possibly you could see increased calcium pyrophosphate deposition in joints and therefore an attack of pseudogout. The way you differentiate gout from pseudogout is by analyzing the synovial fluid. In pseudogout, you will see crystals in the synovial fluid that are rhomboid in shape. They are positively birefringent, and this is different than gout, where the crystals are negatively birefringent. And in addition, the crystals are blue when they are parallel to the polarized light, in contrast to yellow for gout. And shown on the screen is an example of some of the rhomboid crystals. You can see one right here. So we talked about how Cppd can be asymptomatic and discovered on routine imaging. We also talked about how it can lead to an acute attack of arthritis called pseudogout. The third way that Cppd can present clinically is as chronic joint disease. This is sometimes called pseudo-osteoarthritis because it looks just like osteoarthritis. Patients present with complaints related to progressive joint degeneration. And if you study patients who have asymptomatic Cppd in their joints, about 50% of them will go on to develop chronic joint disease in those joints, similar to osteoarthritis. Basically, what's happening here is the calcium pyrophosphate deposition in the hyaline cartilage leads to progressive cartilage deterioration over time, and that's the same thing that happens in osteoarthritis. The cartilage degenerates, and that leads to the condition. So these patients can go on to develop bony enlargement and tenderness, all very similar to osteoarthritis. The treatments for Cppd are shown on this slide. Acute attacks of pseudogout can be treated with joint injections of steroids. This is called intra-articular glucocorticoid injection. Basically, you inject steroids directly into the affected, swollen, and painful joint. You can also treat acute pseudogout attacks with NSAIDs and colchicine. If patients have multiple pseudogout attacks, they can be placed on colchicine chronically as prophylaxis. And then finally, when patients develop chronic joint disease from CPPD, this is basically treated the same way as osteoarthritis. In fact, some people consider the chronic joint disease of CPPD just a variant of osteoarthritis. There are a number of medical conditions that have been shown to increase the likelihood that a patient will develop CPPD. In other words, these conditions are associated with CPPD, and I've written some of them on the screen here. So if you have trauma to a joint, that joint may later in life develop CPPD. Patients with hyperparathyroidism are more likely to develop CPPD, and you know that hyperparathyroidism can raise the serum calcium level, so that makes it easy to remember that it increases the chance of calcium pyrophosphate depositing in joints. And then finally, hemochromatosis is strongly associated with CPPD, and this is a little bit confusing, so let's talk about this now. In the GI section, I have a video on hemochromatosis, and in that video I talk about how there is a hereditary form of this disorder where patients develop iron overload in a number of tissue beds. And in that video I mentioned that arthritis is common in hemochromatosis, and that's because iron deposits in synovial tissue. If you ever meet a patient with hereditary hemochromatosis, you will find that one of their main complaints is that their joints ache. One of the reasons for this is because of iron deposition in synovial tissue, but another reason is that patients with hemochromatosis very commonly develop calcium pyrophosphate deposition in the hyaline cartilage. 2/3 of patients with hemochromatosis have CPPD. The reason for this association is not understood. This is just something you have to know, but there are two reasons for the joint pain in hemochromatosis. One is iron deposition in the tissues. The other is CPPD, and you just need to be aware of that. And that concludes our video on CPPD.